Very fun. Um, Apologies, everyone, that I was late. I was actually giving another actually 2 hours of back-to-back lectures to my residents. So I'm very sorry that we ran overtime on that. Um, Welcome and thank you for joining us for CMES Journal Club today. I'm sure people are going to trickle in as we go along. We are going to skip the baseline multiple choice questions that we normally do because I was running late today, and again, apologies. I would like to welcome Dr. Lincoln Brown today. Lincoln was previously an emergency medicine resident and is now transitioning to pediatrics, and he's here to talk to us today about pediatric otitis media. And he was previously a paramedic. So Lincoln has a long background in emergency care. And I think the topic we're talking about today is really important for both emergency and primary care settings. And I'm looking forward to hearing about some of the latest guideline updates. As always, please chime in on the chat if you have questions or comments. And Lincoln's going to ask questions to try and keep this interactive, so we appreciate your participation. And without further ado, I will let Lincoln take it away, and you should be able to screen share.
Okay, let me see if I can. All right, so why is it not letting me? Stand by. There we go.
I can try making you a co-host. Sometimes that will do it. Oh, it's working great.
There we go. Yeah, let's do. There we go. Can everybody see that?
Yes, you're good.
Okay, great. So, good afternoon, good evening, wherever you might be. Thanks for joining. I'm very happy to be here. Thanks, Dr. Pelletier, for the great intro. Let's talk about acute otitis media. Again, this isn't going to be kind of that broad, let's talk about every aspect of acute otitis media. This is a deeper dive into the most recent guidelines of it. Um, and with the guidelines comes a little bit of an academic side and a little bit of a clinical side. We'll try and keep those separate, as well as trying to distinguish our clinical side versus what other people may experience in their clinical settings. And this is where the conversation and the dynamics of this should hopefully be very interactive. So please, as Dr. Pelletier said, join in comments, questions, concerns. Would love to hear them. So the guidelines are US based, US research, and US focused. So we'll use that as the launch board to other conversations. So, brief agenda for the day, quick disclosures, a little bit of intro, some cases to get us thinking clinically. Background is to the origins of this guideline and why it was reviewed. A little bit of a deeper dive into the current guidelines, and then a wrap up coming back to those clinical cases. So, yes, I am a poor resident. I have nothing to disclose. I have no vested interests, and I do not have any controlling interest in any of the products listed here. I am, however, open to conversation. So, why? Why are we talking about otitis, acute otitis media? Well, simply put, it is the single most common reason antibiotics are prescribed to children in the United States. So with that comes lots of discussion, lots of arguments, lots of conversations, and lots of guidelines. Very generally, it is for this guideline, children otherwise healthy, 6 months to 12 years with uncomplicated otitis media. That is signs and symptoms of inflammation of the middle ear. So we will dive much more into this definition here in just a couple of slides, but that gets us started. So prior to the original guidelines, lots of kids had otitis media. Lots of kids were given antibiotics for it. The guidelines came out. The number of diagnoses went down, the number of prescriptions went down, but the relative percentages have actually stayed pretty flat. in terms of the prescribing of antibiotics for acute otitis media. This is something we will come back to towards the end. Also, we're going to discuss the new practice guidelines. They are split into two sort of buckets, the diagnosis of acute otitis media, and a new, more stringent definition, and the treatment, which is going to be individualized by age, laterality, severity, and includes now a close follow-up observation option as well. The article would not be complete if there were not a bunch of abbreviations in there. The ones that we are most interested in are otitis media versus acute otitis media with effusion, and middle ear effusion. Just as a reference, these are some of the other ones that were included in the article, um, here for your viewing pleasure if you like. So the definitions, as I said, we're going to come back to this and get into detail because this was one of the key points of the new guidelines in 2013 was a much more strict definition of acute otitis media, differentiating it from otitis media with effusion. Generally speaking, two broad categories: complicated, uncomplicated. For the sake of the guideline, uncomplicated was outside of the scope, and they simply defined it as the opposite of uncomplicated, that which was helpful, but not really. In the uncomplicated category, they broke it down into severe and non-severe. Severe being moderate to severe pain, pain greater than 48 hours, or temperature over 39 degrees Celsius. Non-severe, again, being not severe. That will come back to become important when we really start talking about treatment. With the 2013 guideline, they also included now recurrent otitis media. That was not included in the original one. Defined as 3 or more separate, well-documented episodes of AOM in the last 6 months, or 4 episodes in 12 months, with at least one being within the last 6. All of this was the distinction against otitis media with effusion. The fluid in the ear with um, inflammation, but without signs or symptoms of acute infection. This is that kind of gray area where is it acute otitis? Is it not? They're trying to make it a very clear distinction between these two. And then the very bottom of this was middle ear or is effusion in the middle ear, without any reference to who, what, why, when, or how it got there. So now that we have acronyms, we have definitions. Lovely. Let's get into some cases. Let's start thinking about how we do this clinically. So, 10-month-old male, fever of 39.3 Celsius for 24 hours, irritable, pulling at the ear, decreased oral intake, no antibiotics in the last month. On exam is a moderately bulging right TM with erythema. It is immobile and the left ear is normal. Do we classify this as acute otitis media? This is the participation part, by the way.
And please feel free to chime in the chat if you don't feel like speaking out loud. We definitely want this to be engaging and bi-directional. What's your diagnosis? It looks like
acute otitis media.
Thank you, Loretta.
Yes. Acute otitis media, absolutely. Unilateral, acute otitis media in a less than 2-year-old with moderate to severe symptoms. We'll come back to treatments towards the end of this. But let's compare that with a 4-year-old female, mild left ear pain for a day, afebrile, eating and playing normally, mild bulging of the TM on the left, right ear looks normal. Is this still acute otitis media? And probably
No,
the,
it's not. Uncomplicated otitis media.
so I apologize, I did not catch that. I'm sorry.
I think she said uncomplicated otitis media.
Uncomplicated otitis media. Okay, great. This is one of the ones we'll come back to in much more depth, but would you prescribe antibiotics for this patient? Think about that one for a minute. Let's move on to, so yes, unilateral acute otitis media, over 2 years old with mild symptoms. How about an 18-month-old female? Fever, 38.8, fussy, poor sleep, pulling on both ears. Both TMs are bulging, they're opaque, and with markedly decreased mobility. Acute otitis,
Feel free to chime in the chat.
No, not acute. I
also
don't
acute.
think it's acute.
She said non-acute.
I don't think it is acute.
Okay. Due to the duration,
The
because,
number of days, the duration.
okay. Yes, room for debate as to whether 2, 3 days takes it out of the acute category. Per the guidelines and kind of a spoiler alert for things to come, they will still call this acute otitis media. Um, the emphasis also being on that it is bilateral and that the patient is less than 2 years old. By the guidelines, this will still fall under the acute category. Last but not least, let's talk about a 3-year-old male who was diagnosed 3 days ago, taking amoxicillin, still has a persistent fever of 39 Celsius, worsening pain, persistent bulging and erythema of the right TM with purulent middle ear effusion. Is this still acute?
Yes, I think so.
Okay. Would this also qualify as treatment failure?
Yes, yes,
Indeed. So persistent acute otitis media, 48 to 72 hours with appropriate therapy is now falls into the category of treatment failure. We'll touch on that one as we get into the guidelines. So first guideline came out in 2024. It spawned a lot of discussion, a lot of further research, and in the interval between 2004 and 2013, we also had some new vaccines come to market. The new guideline then also addressed recurrent acute otitis media. So why this strict definition? There was not a very strictly defined definition of acute otitis media in the 2004 guideline. And because of that, it was it included more otitis media or otitis media with effusion and acute otitis, kind of blurred the results a little bit. They want to be more specific, and the authors of the article of the guideline specifically addressed the fact that they want the specificity, accepting that there might be a lower sensitivity. Some of those very mild acute otitis media cases may get missed, but this is kind of was their goal with the 2013 revision. That specificity was decided upon because it helps define what is being treated and what is not. So otherwise healthy, 6 months to 12 years, um, not complicated. And that complicated, again, if you remember, is anything that has drainage out of the ear. That could be a ruptured TM, that could be due to tubes, could be craniofacial abnormalities, cleft palate, immune deficiencies, cochlear implants, anything like that that puts it in the complicated category, takes it out of this guideline, and most likely will start off with antibiotics, given the complicated issues that are already at present with these patients. So we've clearly defined what we're treating, what we're not treating. It also provided a uniformity to the research. So is this OME or is this acute otitis media? Let's be specific. That way we can take our data, pool the data, get better power on our research, and come up with better treatment options. It also becomes important when we talk about the application of treatment for these patients. As you saw with those 4 cases, we're going to talk about observation of some of these patients, and we need that very strict definition to decide who gets observation and who gets antibiotics. The authors were polite enough to give us a brief reminder of the structures with specific emphasis on the short process and the long process of the malleolus as well as the pars. So normal, pearly gray, translucent, mobile with a good light reflex. As we start to get effusion, the short process gets less well defined. The long process or the malleolus gets shorter in appearance. We start to see the bulge. As that gets to moderate, those structures become more obscured, and by the time we get to severe, they're unrecognizable. And on this one, you can also see very nice purulence behind the TM. They also reference the use of pneumatic evaluation to see if you can get movement with positive or negative pressure. That will be an important part of the diagnosis going forward as well. So acute otitis media. Now that we've gone through all these definitions and all this stuff, what is it? It unfortunately does not have a gold standard for diagnosis. It is on a spectrum. It requires middle ear effusion plus acute signs and symptoms of middle ear inflammation. So the authors looked at some of the differences. Symptoms alone, ear pain, only 50 to 60% sensitive. Validated symptom scores did a very poor job correlating with diagnosis, and especially if it was in a preverbal child. Versus the signs that we see, that bulging, that's 97% specific, but only about 50% sensitive. The impaired mobility, the positive and negative pressure, a little less specific, but much more sensitive. And the cloudiness, also important. So, which is better? Do we look at the signs? Do we look at the symptoms? Um, Moderate to severe bulging is the most single most sensitive finding, but really it's the combination of both. We need that cloudy, bulging tympanic membrane with impaired mobility, with acute signs, or excuse me, acute symptoms of uh, infection. That is our best diagnosis for acute otitis media. As I said, it's on a spectrum. It starts with middle ear effusion. It turns into an otitis media with effusion, but acute signs of infection are absent. And then it transitions into acute otitis media, bulging membrane, erythema, pain, and kids can fluctuate back and forth on this spectrum. Um, Research showed that at 2 weeks after successful antibiotic treatment, 60 to 70% of kids will still have a middle ear effusion. That middle of ear effusion can turn back into OME and turn back into AOM. This is the suspected kind of recurrent acute otitis media process. But you can see that kids continue to have fluid in the ear for a significant period of time after the resolution of an acute otitis media event. So, as let's get into the meat of the guidelines. What are their recommendations for acute otitis media? Again, we've beat on this long enough. There's no single diagnostic source. It includes infusion and signs and symptoms. Recommendation number one was the diagnosis of moderate to severe acute otitis media. Again, that nod to complicated otitis media being the far end of that spectrum. They do reference drainage. That was simply just a sort of as a note. As a kind of acquiescence to letting a little more sensitivity uh, to the diagnosis, they came up with the recommendation that a mildly bulging TM with intense erythema or pain uh, can also be an acute otitis media. As you can see, it's a grade C recommendation. It's a little bit more of that. That's more of the hedge to make sure that we don't get too specific and miss a large number of acute otitis media diagnoses. And they authors were extremely persistent with their conversation regarding what is not acute otitis media. And that comes with pneumatic evaluation of the tympanic membrane. Recommendation number two, also lots of emphasis on this one. Acute otitis media hurts. Little kids are unhappy, they're uncomfortable. So assess the pain, and if they're in pain, treat it. This was a very strong recommendation from the guidelines. First line is acetaminophen or ibuprofen. Um, Topical can add brief benefit if they're over 5 and have an intact TM. And then narcotics for severe pain only due to respiratory depression risk in kids. They made a very diligent point that antibiotics are not analgesics. It takes at least 24 hours for antibiotics to start to relieve the pressure and thus the pain in the ear, and that approximately a third of kids under 2 still have pain 3 to 7 days out. So assess for the pain, treat the pain. Now, the fun part, the part we've all been waiting for, antibiotics. Who do we give them to? Severe otitis media, any age, greater than 6 months, unilateral or bilateral. Strong recommendation, give these patients antibiotics. If it is non-severe symptoms, but it is bilateral in nature and they are younger, 6 months to 2 years. These are the ones that also do very well with antibiotics and should receive antibiotics as well. This is the part that will probably stir a lot of conversation. Observation with close follow-up. This was the new recommendation and why they went with a very specific definition of acute otitis media. There are cases that they feel can do well with close follow-up. Non-severe, unilateral, 6 months to 23 months can get antibiotics or observation with close follow-up. Additionally, non-severe, over 2 years old, unilateral or bilateral, also falls in that category. Now, this is a decision they emphasize needs to be made in conjunction with the parents or the caregivers. From a US standpoint, some of the biggest concerns that parents have when they bring their children in for acute otitis media is the pain that the child is in, the fact that the kid is missing school or daycare, and the parents are missing work. If this is a mild case and coming back to that analgesic emphasis that they had, treating the discomfort, making the child comfortable again, and allowing these non-severe cases to play out and avoiding the use of antibiotics was a very real emphasis in this guideline. The caveat has to be a mechanism in place for this follow-up. Are the appointments available? Are the providers available? Do the parents have transportation and a means to get back to have reassessment or to pick up a safety script if it's available? This was the root of this new guideline. And for people like me that like pretty graphs that sum it all up in one place, here we go. On the left, again, that nod to complicated acute otitis media, it gets antibiotic therapy. It is complicated. Otherwise, for younger kids, unilateral or bilateral, they get antibiotics. If they're older, then that's where we start getting into some of the observation options. This diagnosis came with a new emphasis in the guidelines that the use of pneumatics to evaluate the tympanic membrane is vital to the diagnosis of acute otitis media. They also suggest that provider skill is something that needs to be addressed, and it needed to start in medical school, followed by evaluation or continued education in residency and continuing education after residency. They listed some resources, some videos, Johns Hopkins training CDs, web-based programs. They also were very clear about what is required in terms of equipment, light sources, airtight seals on the speculums, tools to remove cerumen. This is also a point where I can see a lot of contention, a lot of differences in regional availability. It's nice that there's an online something if you have the internet and can access it. We'll come back to that in a minute. Key action number 4, the second most important slide in this whole deck, if you forget everything else. What are we prescribing to the ones that we have said have acute otitis media? The recommendation, amoxicillin. High dose amoxicillin is the first line. Their rationale for that is that high dose covers the minimum inhibitory concentration in the inner ear for some of the mildly resistant strains that cause acute otitis media. It's effective at the high dose range. It's inexpensive. It's safe. We've studied it a bazillion different ways. And it has a narrow spectrum and has fewer side effects. If amoxicillin isn't appropriate, and we'll get into the ones where that may be the case, you can add beta lactamase coverage, Augmentin being our go-to for that. If they have an allergy, a true allergy, we can look specifically at ceftonir, the molecular structure being different enough that it should be safe for those with penicillin allergies. And if there is antibiotic failure, reassess after 48. The definition of that is a reassessment after 48 hours with no improvement or worsening symptoms. Can either change antibiotics or drain the fluid if that were the decided upon treatment course. Again, people like me that like it in a nice graph form, we have the high dose amoxicillin divided twice a day. When we say initial treatment, both immediate and delayed start, that is a nod again to the observation with close follow-up. And then if we get into antibiotic resistance or failure. Of course, amoxicillin tastes great. Augmentin, not bad. Some of the rest of them get kind of nasty to downright putrid. If the kid's not going to drink it, maybe we need to consider other options, IV or IM. The authors spent a lot more time on this. I think it's pretty self-evident. Duration of therapy, if they're under 2, give them 10 days. If they're 2 to 5, 7 days. Over 6, 5 to 7 day course should be sufficient. A bit of interesting knowledge that I learned going through this was that the traditional 10-day course was not based on the study of acute otitis media. It was based on streptococcal pharyngotonsillitis and thus extrapolated to acute otitis media. Routine follow-up that has very little scientific evidence for the 10 to 14 day follow-up based on clinical course. If you're worried about the kids, bring them back, reevaluate them. If it's pretty clear-cut, straightforward, and no big concerns, they should be fine. For us in the United States, strep pneumonia, number 1, Haemophilus, number 2, Moraxella, number 3. We have seen a little bit of a shift with the introduction of PCV vaccines. We'll touch on that more here on the next slide. Group A strep, uncommon cause, less than 5%. After the 2004 guideline came out, the first PCV vaccine, PCV7, was introduced. There was a temporary dip in strep causing acute otitis media that then recovered. And what they found was basically it was the non-PCV vaccine strains that were still causing the otitis media. Since then, we've had PCV 10, 15, 20, 21, and 23. 23 doesn't have much in the way of application to children, but the 15, 20, and 21 do here in the States. Is this something that you guys are seeing or using?
Which type of pneumococcal vaccines are available where you're working? Oh, and by the way, there's some information in the chat. Lincoln, I had asked what oral 3rd-generation cephalosporins are available where folks are working. It sounds like cefixime. I don't think ceftonir is available at some of these sites. Some people are using ceftriaxone if they've got otitis media that fails outpatient oral antibiotics.
Okay.
Which types of pneumococcal vaccinations are you using in your settings? Feel free to chime in the chat while Dr. Brown moves forward.
Just for reference, if you want to look back at the slides, here's kind of the pediatric dosing schedules for 15, 20, and 21. Not something we're going to spend a lot of time on at the moment. This is simply this came up in the guidelines that when they published the 2013 guidelines, the non-typable Haemophilus, there was a vaccine that was in trying to be developed. As of when I put this PowerPoint together, no vaccine typing or targeting non-typable H influenza is available anywhere in the world. So there are some kind of similar things. Here's some information if you want to read it on your own. Before we move on, any comments on PCV vaccine usage?
No comments in the chat.
So for us, it is obviously an evolving and growing area of interest. I think what we're going to see is our continued pressure on the bacteria continuing to shift towards non-PCV strains. We're doing better. We've got more coverage, but I think we'll still continue to see that shift, but maybe strep pneumonia becomes less common. We'll see. Action 5, don't prescribe prophylactic antibiotics. This was another pretty contentious point that they brought up. The benefit is modest. It reduces the case by about 1 a year, and it has to be continuous therapy. As soon as you stop, the benefit goes away. The side effects, the risk of side effects, the severity of the side effects, and the possibility of drug-resistant infections goes up significantly with the use of prophylactic. So for the committee that put out the recommendations, not the risks don't really outweigh the benefit. Their recommendation, you can offer tubes. In the proper patient, tubes can have significant improvement in quality of life. However, they do also carry surgical and anesthetic risks, and they also carry a moderate risk of long-term structural changes to the TM. So not the perfect solution, but an option. And last but not least, prevention. Coming back to the PCV vaccine, if you have it, give it. Great. That was a strong recommendation. Again, they did see cases dip after the initiation or the introduction of PCV7. Those did rebound back to the non-typable. We'll see what happens going forward. They also recommended a flu vaccine. Rationale is that a large number of acute otitis media follow viral upper respiratory infections, including the flu. So give them a flu vaccine. Encourage mothers that are breastfeeding to breastfeed for at least 6 months and avoid tobacco smoke. This was a highly contentious or highly debated, I should say, recommendation. There's probably a benefit, not the strongest benefit in the world. Honestly, the bigger benefit comes to the person that stops smoking. But it is a recommendation nonetheless. So thank you for sticking with me through the weeds on all the recommendations. Let's get back to the clinical side of this. Our first kid, the 10-month-old, unilateral, moderate to severe symptoms. How do we treat this kid? How do you treat this kid?
I'm definitely giving antibiotics for this kid. She's less than 2 and has moderate to severe symptoms.
I love it. Sounds fantastic. And don't forget to treat the pain. High dose amoxicillin twice a day, 10 days. What about our 4-year-old? Unilateral and mild symptoms.
Feel free to chime in out loud or in the chat what you would do with these people. Personally, I'm doing a wait and see approach for this patient. I'm going to probably give the parents a prescription for amoxicillin, but tell them not to have the kids start it unless things are getting worse over the next couple of days.
I think that sounds fantastic. I'm curious in the providers out there if from a kind of a where you practice standpoint, is there a difference? If this patient shows up in the emergency department, is that one thing versus if they show up in clinic?
Yeah, I would definitely love to hear from people in the chat how they're approaching this. I know, at least in my setting, if someone does not have a pediatrician, like they don't have access to primary care, or the parents are not the most reliable, I'm definitely giving them that wait and see antibiotic prescription versus if the patient has great follow up, I might just skip the antibiotic and tell them to see their pediatrician in the outpatient setting.
I know one of the things as an intern in emergency medicine, I spent 2 months in our pediatric emergency department. And one of the things that we could do was schedule that follow-up appointment for the patient. That gave me a level of reassurance that at least it's on the books. I can give that to the parent. If I wasn't able to do that, that changes how I look at what I'm going to do with this patient, back to kind of what Dr. Pelletier was saying. Other thoughts, considerations?
We didn't get any other thoughts on that, but I did get a few more responses about pneumococcal vaccination. It sounds like, at least in Uganda, where most of our attendees are from today, actually, I think everyone's from Uganda today, which is interesting. They said that folks usually receive their pneumococcal vaccinations at 6 weeks, 10 weeks, and 14 weeks of age. So very early, which is great. I mean, covered super, super young.
Yeah, that's fantastic. Did they say which one they were giving?
No, I'm not sure. So if Mary, I think you had written the schedule in the chat. If you wouldn't mind sharing when you get a chance which pneumococcal vaccination, that would be awesome. I'm just curious. And then it sounded like universally people have cefixime available as an oral cephalosporin if they have someone who's refractory to treatment and are having to get to like third line agents, or if there's allergies. And then they do have ceftriaxone.
Gotcha. Okay. That is interestingly, they specifically talk about ceftriaxone in the article, and that only in the sense of it coming back to it really tastes bad. That is one of the ones that they considered for maybe an IM injection. The other one, I don't have any idea. Are they successful giving it orally?
Don't know. Mary, you'll have to tell us, or someone else who wrote suffixeme in the chat. Loretta, I think you had written that too. Um, yeah, if you want to continue to the next case, that's fine, Lincoln. I'm sure people will continue to chime in.
Sure. We'll get back to. Okay, our 18-month-old bilateral acute otitis media. What are we doing for this one?
Would you treat this patient with antibiotics? Oh, and the answer to your question, Lincoln, is that they have PCV10 in Uganda.
Okay.
Well, Loretta says yes, and I agree with her. This kid's less than 2. They've got bilateral otitis media. They are definitely getting treated.
Absolutely. And of all the patients in the research that drove the 2013 guideline, this is the one that had the most benefit from antibiotics. So bilateral, less than 2. So yes, absolutely. The again, also with bilateral or the younger ones treat the pain as well. Okay. Our 3-year-old with persistent otitis and potential treatment failure. What are we doing for this kiddo?
I think we've bought ourselves a second line agent.
I think so. Initial recommendation is switching to something with beta lactamase coverage. If that doesn't seem appropriate, then yes, we're into some of the other options. This, for me, this kiddo is the one that also buys very close follow-up. Switch the antibiotics, and reevaluate 24 to 48 hours. Clearly, we've got potentially something more going on that needs to be kept track of. Okay. So, challenge, we've alluded to it through the chat today. There are points where there can be challenges to this guideline. The most interesting challenge, and one that got a lot of attention in the article, the biggest challenge really is us. It is those of us that are seeing the kids and prescribing the antibiotics. As I mentioned at the very beginning, the percentage of prescriptions really didn't change when the number of diagnoses went down. They did a survey, almost 500 primary care physicians after the 2004 guideline, and essentially the prescribing rates went unchanged, and the physicians were less comfortable changing their practice despite the guidelines. So, what do we do about that? It is kind of a rhetorical question because I don't have an answer to it. How do we get these guidelines out there? How do we follow them? Um, there are other challenges that probably play into why physicians or providers are not following these guidelines. One of which is follow-up mechanisms. Is there a way to do that safety net or wait and see prescription? Is there a way for the patient to come back to pick up the prescription? Reliability of the patient, other factors involved. Oop, sorry. Their new definition requires proper equipment. And if you don't have the pneumatic aspect to evaluate movement of the TM, technically that is required for the diagnosis of acute otitis media. If you don't have the tools to remove the cerumen and are not able to visualize the entire TM, this may be a bit of a challenge to be able to diagnose it and therefore err on the side of caution, prescribe the antibiotics. As we alluded to before, the availability of training and recurrent training is, can you start in med school and residency and post-residency and get the training web-based or in person that is needed to maintain the skills? And then what is access to the pharmacy? So this was a US article with US basis and bias, and they relate to alternative medicine or complementary medicine, which in some cases may be normal medicine. They don't recommend any of these treatments because there aren't controlled evidence-based research for them. Thus, they cannot, quote, recommend them. That doesn't mean they don't work. So there are other aspects of this that weren't included in this that ought to be addressed. The big thing is where your local practice is. Are there home remedies that are often used that might conflict or interact with any prescriptions that you might give the patient? Something be aware of, um, trying to minimize that interaction. Other challenges that haven't been addressed.
Can you think of any limitations to these guidelines in the setting where you were? Feel free to chime in the chat while Dr. Brown goes through our take-home points.
The most recent Uganda guideline, since sounds like everybody is there, this should be familiar. I think it's interesting. It is very straightforward. It does not delve into the laterality and age distinctions. It is simply, here's what we do.
I think it's a good thing too to keep in mind. So the Uganda guidelines, Dr. Brown, are used by a wide spectrum of healthcare workers, and so they help make the simplicity. I think is wise because there are sometimes like nurses taking care of patients in rural settings. There may not be physicians out there, so the guidelines we got into today are a lot more detailed in terms of age and laterality of infection and all that, but keeping it simple sometimes can be easier because as everyone saw, a lot of folks who were surveyed about whether they're following these new guidelines aren't doing them. I think it's good to spare antibiotics when someone potentially doesn't need them, but also sometimes making it more complicated can be overwhelming.
Absolutely. Yes. The straightforward, here's what it is, here's what we're doing, keeps it very simple and very applicable to a wide range of providers. Gambia, same thing. Again, resource limited, simpler guidelines that can be done by a wide range of people. Back at MU, we tend to err more again on because of where we are and our availability of all sorts of things. We tend to generally follow these guidelines. We start with high dose amoxicillin. If they've had recent amoxicillin use or other concerns, we switch to augmentin. If we have an allergy, our go-to tends to be ceftonir. And treating with acetaminophen or ibuprofen, acetaminophen, especially if there's fever present, or the alternation of the two are our primary analgesia that we use. So for the most part, we tend to follow those guidelines. But given our setting, that is more of our in line with what we can do. In summary, after all of that, know the definition of acute otitis media, get the proper diagnosis of AOM versus OME, prescribe antibiotics only when needed, support the observation and close follow-up when it's appropriate, don't use prophylactic antibiotics, and encourage prevention. References for where the information came from. And thank you. Thank you for your time.
Thank you so much to Dr. Brown for presenting today. We really appreciate everyone's engagement in the chat. I saw there was just a question from Sheena about how many days for amoxicillin. I know she joined a little bit late. Sheena, generally the guidelines say 10 days for treating with high dose amoxicillin in terms of our first line antibiotics. And then Betty commented in terms of home therapies in Uganda, people sometimes use herbs in the villages. She's not sure of the English names for those, but it sounds like there are home remedies being used there just like there are here. I just shared the answers to the multiple choice questions. Hopefully everybody can see those. And the first question was, which finding is most helpful for diagnosing acute otitis media? And the answer for that one is middle ear effusion plus moderate to severe tympanic membrane bulging. The second question, a 4-year-old with mild unilateral ear pain for 1 day who's afebrile and playing normally. The most appropriate management would be a wait and see approach. So observation with analgesia and close follow-up or antibiotics is an option if someone does not have good follow-up. So everyone got that right, which is great. Everyone got the next question right too. The first line antibiotic for children with uncomplicated acute otitis media is high dose amoxicillin. And Sheena, I saw your comment in the chat. It's 10 days for high dose amoxicillin therapy. For number 4, a child with acute otitis media has persistent fever and worsening ear pain after 72 hours of appropriate amoxicillin therapy. And the next best step will be switching to amoxicillin clavulanate. I saw one person answered clindamycin. That would be a reasonable choice if the patient has a true allergy to amoxicillin or, well, I would say cephalosporins, since clindamycin would be more of a third line agent. And then the last question is, which intervention is recommended to help prevent recurrent acute otitis media? Everyone got this right as well. It's pneumococcal vaccination and annual influenza vaccination. It looks like Dr. Brown has the durations pulled up on the screen in case anyone was curious. The 10-day course is for folks who are less than 2. The older you get, the less days you really need. I would say, I think the Uganda guidelines, did they put a duration on there? I can't remember.
5 days.
They put 10 days?
5.
5. Okay. So you guys are on the shorter end, which I think is great. Not everyone needs 10 days, right? So take a look at these guidelines in terms of the duration of therapy. For less than 2 years old, it's definitely 10. And for kids as they get older, you can get away with less days, but follow your local guidelines. So if they say 5, then you should do 5. There was one other question here. Regarding the use of paracetamol, won't this mask fever? That is a really excellent question. Yes, it will mask fever and NSAIDs will as well. However, we do need to treat patients' pain. And so I would say kids are generally going to become lethargic and not want to eat and drink, and they'll look ill if they're developing meningitis or sepsis. And so watching for behavior changes, eating and drinking changes, those other things, and hopefully if they get meningismus, you'll know, but looking for other stuff besides just fever alone in terms of development of complications, I think would be a good way to go, given that it's important to treat their pain so that they will want to keep eating and drinking because most kids are going to feel terrible when they've got a fever. I think that's all we've got for you, Dr. Brown. Any other closing thoughts before we wrap up?
No, I don't. That pretty well covers it.
Awesome. Well, thank you everyone so much. We will send out the recording of this session, and I will send out a summary document that contains the link to the slides as well as a link to the YouTube video.
Hi, Pelletier. Hi, Pelletier.
Yeah, go ahead,
Hi,
Emmanuel.
Pelletier. Yeah, lovely. Lincoln, I listened to your presentation and I'm pretty happy with some of the submissions that you made. Well, I just have a few comments to enrich some of the submissions that you had made. Well, first and foremost, looking at the 2013 guideline, intricately, there are areas of controversies, particularly with use of alternative medicines, naturopathic drops, etc., etc. Then conflict around initial antibiotic initiation and subsequent conversion to antibiotic administrations, just to mention a few. So the way to go is to look forward to the review of the current guideline that we have now. That's my first comment. Then other comments that I have after reviewing that guideline, I'm going to send up to enrich this presentation, this beautiful presentation that you have made. I do not expect less from you looking at your profile. So congratulations and well done, Lincoln. Over. Pelletier, over. Over, Pelletier, over.
Emmanuel, thank you so much for all of your comments, and we'll definitely incorporate a lot of that into the Journal Club summary. I do have to go because I have another meeting, but thank you all so much for attending, and we will see you next month.
Thank you.